Hi, my name is Shanika Noel, and I'm a Doctor of Behavioral Health Management candidate here at Arizona State University. And I'm going to present to you my final project entitled Enhancing Integrated Healthcare Delivery by Improving Referrals to Psychosocial Care for Cancer Patients. Psychosocial distress is a prevalent and under-addressed concern in cancer care, with studies indicating that 25 to 50% of patients experience significantly psychological challenges, such as fear of recurrence, depression, and anxiety, alongside secondary concerns, which include financial strain and changes in physical appearance. While distress screening tools improve detection, evidence shows that screening alone is insufficient. Meaningful improvements in referral quality and patient outcomes occur only when screening is paired with structured evaluation and integrated into routine clinical care. Given cancer's global burden with nearly 19 million new cases annually and half of patients experiencing psychological distress, the lack of integrated psychosocial care represents a critical gap. Addressing this requires systematic implementation of validated distress screening and evaluation protocols, coupled with coordinated interdisciplinary approaches that elevate psychological care as a core component of oncologic treatment. The goal of this study is to integrate an intermediary response screening called an IRS, which is a formal evaluation of patient-reported PNS responses as a required activity before entering the PNS results into the Epic system. This will be piloted at MD Anderson Cancer Center, where their proprietary distress screening tool is called the Patient Needs Screening, which is lovingly called the PNS here. By adding a 2 to 3 minute IRS into the existing nurse-patient encounter, social work is better resourced to provide psychological screenings to the most at-risk population of cancer patients, thereby improving consult conversion rates for social work, which will likely improve referrals and completed visits to integrative medicine and/or psychiatry. The independent variable for this study is the intermediary response screening, which will be included in the nurse-patient encounter as an evaluation step following the PNS, prior to entering the scores from the PNS into the EPIC system. It's kind of a validation check, if you will. The dependent variables include a 1 to 3% improved conversion rate for EPIC triggered social work intervention, a 1 to 3% increase in completed Columbia Suicide Severity Rating Scale, which is the social work further evaluation document used if triggered, 3 to 5% increase in referrals to integrative medicine and/or psychiatry, and a 3 to 5% completed visits to integrative medicine and/or psychiatry. The initial PDSA cycle commenced in November 2019 and completed December 2019. This was a 30-day pilot study that involved daily data collection for the endocrine center and head and neck centers at the close of each business day. Approximately 680 to 700 distress screenings were administered each day to new and consultative patients across both clinics. The ANOVA data collection method was used to evaluate baseline data against post-implementation data. Baseline conversion data reflects EPIC triggered social work requests based solely on patient-reported responses on the PNS without an IRS evaluation. So this is the pretest data. Whereas implementation conversion data collected reflects social work requests triggered by the system algorithm, adding the IRS evaluation step. So this is our post-test data. The initial phase of the implementation encountered some internal contextual factors that delivered less than optimal results. The pretest data compared with the post-test data showed that less than 0.5 difference in between the p-values of the baseline data and post-implementation data. Since 95% of post-test data fell within 2 standard deviations of the mean, it was concluded that the intervention did not produce a significant change in the outcomes. The initial implementation results expressed that while the addition of the IRS evaluation step proved to better identify patients who required further psychological evaluation, It did not effectively result in an increase in psychosocial referrals nor completed visits to integrative medicine and/or psychiatry. And specific to the dependent and independent variables, the initial PDSA cycle of the implementation generated the following outcomes: improved conversion rates for social work encounters, resulting in an increase in completed CSSRS evaluations. Unfortunately, the increase in CSSRS evaluations did not correlate to an increase in referrals to integrative medicine and/or psychiatry as originally hypothesized. The initial pilot yielded less than a 3% increase in referrals to integrative medicine and/or psychiatry due to systems access restrictions for social work, which also resulted in a less than 3% increase in completed visits to integrative medicine and/or psychiatry. The setting for my project is the University of Texas MD Anderson Cancer Center, located in Houston, Texas. According to the Substance Abuse and Mental Health Services Administration, MD Anderson is a level 4 co-located healthcare facility. Although MD Anderson is a cancer hospital, it provides coordinated care like cognitive behavioral therapy, stress management, yoga, acupuncture, music therapy, and other services through their Integrative Medicine Center and the Psychiatric Oncology Center. The availability of these services was a facilitator to the implementation due to the provider's aligned interest in holistic care. The endocrine center and head and neck centers were carefully selected to ensure minimal disruption, if any, to operations. The stakeholders that were included in this implementation were oncologic specialties from several ambulatory outpatient centers, the chief nursing officer, directors and managers from social work, the executive director of patient access, VP of patient experience, the executive director of quality improvement, behavioral health consultants, psychiatrists, and VPs and managers from ambulatory operations. We also disclosed to patients in the endocrine and head and neck centers that an EBI was being conducted, and it was necessary to gain their participation, although the study would be blinded. Also are the implementation team listed down below in more detail. Off to the right, you see the engagement levels of each of the implementation team members based on their contribution to the initial PDSA cycle. Post-implementation interviews conducted following the initial implementation cycle identified several barriers and facilitators to implementation. Some of the barriers include social work's inability to refer patients for psychosocial services, which inhibited workflow. Another barrier was caregiver engagement that was disclosed during post-implementation interviews with stakeholders. And insufficient insurance coverage to support continuous behavioral health visits was also indicated. Lastly, the lack of a purveyor, which is our quality improvement specialist, was also a barrier to implementation. Some of the facilitators that were identified was the care team engagement. The adaptability of MD Anderson was a huge facilitating factor in this EBI implementation. Given that MD Anderson was already administering distress screenings like the PNS to patients, this intervention refined the nurse-patient encounter in a way that enhanced the interaction and promoted a more quality experience. Trialability is another CFIR contextual factor that positively influenced the implementation of this EBI. Since MD Anderson is a multidisciplinary hospital, there were several outpatient clinics that were ideal to pilot the intervention, where reversing course, if needed, would not have significantly impacted clinical operations nor negatively impacted patients. Again, care team coordination was identified as a barrier to implementation during pre-planning, but post-implementation stakeholder interviews revealed that the care team, which included the oncologists, behavioral health consultants, and psychiatrists, huddled daily to coordinate about new and consultative patients and champion the intervention within each pilot clinic. So the rationale for the two prioritized barriers. The most significant deterrent was social work's inability to self-refer patients for psychosocial services, which, although anticipated during the pre-planning phase of implementation, was not adequately prioritized to increase the likelihood of a successful intervention. Since the successful implementation of this EBI starts with the referral being entered timely, it is necessary to prioritize this barrier. Secondly, stakeholders shared feedback from caregivers regarding feelings of exclusion or lack of knowledge related to the intervention. These insights led to further research on patient-reported outcomes or intervention outcomes where caregivers were included versus excluded. Because caregiver support and motivation is invaluable to patient self-management and participation in the implementation, it is also critically important to actively engage and educate caregivers during the PDSA cycle. A less prioritized barrier, but will be included in the next PDSA cycle, is the inclusion of the quality improvement specialist as the purveyor to ensure that this implementation is successful. The theories, models, and frameworks that were used or valued alongside this implementation was the PRISM framework, which was used to assess the contextual factors that were uncovered after the initial implementation cycle. Core processes from the contextual model, like brainstorming and collecting new data, were used to review and prioritize barriers and facilitators. And following the initial PDSA cycle, implementation team members and stakeholders were re-engaged to understand what factors directly or indirectly influence the implementation of the EBI. Brainstorming sessions were held with the implementation team to collectively discuss determinants, prioritize the barriers to address, and then select implementation strategies to deploy during the next implementation cycle. The implementation determinants for my logic model, starting with the process determinants, where stakeholders were engaged during the pre-planning phase to gain buy-in, while the implementation team received training to support the process enhancement. This was a facilitator to implementation. A barrier to process implementation was quality improvement, the lack of a purveyor to engage with daily to improve the likelihood of success. The characteristics of individuals determinants, which was a barrier as well, is that caregivers were unintentionally excluded during the initial PDSA cycle, which contributed to a lack of patient motivation and participation. An outer setting determinant, which was a facilitator, is that research supports a practice gap between psychosocial care in cancer settings. The integrated IRS addresses patient psychological care needs while prioritizing patient care outcomes to effectively reduce suicide rates, cancer recurrence rates, and improve quality of life for patients. Intersetting determinants, one as a facilitator, the other as a barrier. The facilitator is MD Anderson's resource availability to psychosocial services alongside stakeholder and leadership engagement indicated the organization's readiness for implementation. A barrier was social work referral access, which was not prioritized relative to the intervention, which created a process bottleneck. And the intervention characteristics for determinants was MD Anderson already had a psychosocial services infrastructure which promoted adaptability of this EBI into clinical practice, which was a facilitator. Scalability of the IRS intervention was ideal for MD Anderson, given the varied activity levels for each outpatient center, which also was a facilitator. Validated research paired with more efficient social work resource management strengthened stakeholder support for this intervention, which was also a facilitator. How these determinants connect to the implementation strategies. Well, based on the barrier that was identified for social work, we're going to revise roles to enhance referral permissions to social work. Also, an identified barrier was caregiver exclusion. So the implementation strategy to address that is to educate patients and caregivers through information sessions and trainings and offer research to support the intervention. Another barrier identified was the lack of a purveyor, someone to help keep us on our toes and understand what process bottlenecks we encounter during the implementation. And to address that, a quality improvement expert will be engaged more intentionally to oversee the clinical intervention and offer feedback on progress. Another barrier that's not been heavily discussed here, but was indeed identified during post-implementation interviews, was insufficient insurance coverage. That also added an additional burden to patients and impacted completed visits to to psychiatry and integrative medicine. And the implementation strategy to address that is access to expanded psychological health coverage is going to be necessary to cover psychosocial visits along with alternative financial options. And lastly, because this IRS is introduced as a process enhancement, if adopted by MD Anderson, we would want to update the PNS administration policy to include the IRS once the intervention is again adopted. So how are these, what mechanisms are we going to use for these strategies? One is the quality improvement expert. We'll meet with the implementation team daily to offer feedback about the implementation. Secondly, the second mechanism, patients and caregivers are going to be more engaged with the implementation, thereby increasing EBI participation. Third mechanism is payers will be able to understand the need for increased psychological care through the engagement of managed care on the MD Anderson team, and we can possibly negotiate more coverage for psychosocial visits for patients. And the last mechanism is to recruit patients to champion the intervention to increase adoption. I think this will be a great opportunity, not only just for us to have our implementation team as champions, or our care team as champions, but to have patients as champions for the intervention as well. What outcomes are we looking for in relation to our determinants and strategies? One is reach, a 1 to 3% increase in conversion rates for social work consults, a 3 to 5% increase in psychosocial referrals, and a 3 to 5% increase in completed psychosocial visits. Also, we're looking for fidelity as an outcome. The IRS is conducted for every patient who received a PNS in endocrine and head and neck. So the QI feedback that we receive is going to be related to whether or not this intervention was able to be carried out as intended. Feasibility is another outcome. So the CSSRS, which is the Columbia Suicide Severity Risk screening, completion rates will increase as a result of the IRS evaluation. So as we are better identifying through the IRS step, patients who need psychosocial services, conversion rates and completion rates of the CSSRS should increase alongside that. And lastly, adoption as an outcome. At least 95% uptake and adoption into clinical practice is the implementation outcome we're also looking for. Service outcomes, would be patient-centeredness. So the Press-Ganey survey that is regularly administered at MD Anderson will be evaluated to indicate improvements in patient experience, specifically to the endocrine center and head and neck center as a result of the intervention. Another service outcome is equity. Participation rates are going to be more consistent with the pilot clinic demographic. So the makeup of the patients who are seen in those clinic will be also reflected in those who are administered IRS screenings and potentially being recommended or referred for psychosocial services. As well, the last service outcome is effectiveness. So improved quality of life over improved patient outcomes in the pilot clinics. Lastly, the client-patient outcomes, or the outcome proposed by this evidence-based intervention, is patient satisfaction and increased engagement during their journey. Improved referral accuracy for psychosocial services will improve the continuity of care offered at MD Anderson and reduce the risk of suicide and cancer recurrence. The implementation work plan includes the implementation team members, the actions each implementation team member is expected to take, what the target of said action will be, how those actions and how often those actions will be measured, along with the determinants related to the implementation strategies are used to determine the implementation strategies and implementation outcomes. I won't go through each one, but I will select a couple. One, starting with the patients, all new patients and consultative patients will be administered the PNS every 30 days every 30 days, for follow-up patients. The patients will complete the PNS and engage in the IRS with the nurse. The target of that action is inclusive participation, accurate and complete patient needs screening. This will be the number of patients will be recorded daily for 30 days. The strategy is for us to engage consumers based on caregiver non-inclusion. And the implementation outcome related to this is patient centeredness and reach. Another one is the team members, the chief nursing officer. The action expected of the chief nursing officer is to deploy the IRS step to review the patient's responses to the PNS. And so the chief nursing officer is over all nursing administration. So any new protocol or enhancement to an existing protocol has to go through the chief nursing officer, who will then downstream communicate the expectation to nurses in each of the outpatient centers. The action target related to this is to discern the need for further evaluation by social work using the Columbia Suicide Severity Risk Screening. This will be measured through social work referrals reported daily for 30 days. And the implementation strategy used will be evaluative and iterative strategies for outcomes being feasibility and adoption, along with patient-centeredness. My implementation project, titled Enhancing Integrated Healthcare Delivery by Improving Referrals to Psychosocial Care for Cancer Patients, is a quality improvement study. Therefore, the quality implementation framework QIF model was most appropriate to guide the project implementation. Additionally, the QIF model was selected because it best aligned with the proposed hypotheses and desired results to improve patient outcomes, reduce risk of recurrence, and improve overall quality of life for cancer patients. The SIC, or stages of implementation completion, is used to evaluate what phase my project is in, and currently my project is in the implementation phase. Specifically, is in the program launch stage of the implementation phase. So the initial PDSA cycle has been completed. Post-implementation interviews with stakeholders have been conducted, and implementation determinants have been identified. Some post-implementation interviews revealed some implementation determinants that hindered a successful initial pilot. However, the identified barriers were patient caregiver engagement, EHR system permissions, which prevented social work from entering referrals to integrative medicine and/or psychiatry, the absence of a continuous feedback loop, i.e. a purveyor, alongside the implementation team, which highlighted completion progress and our milestones achieved during implementation, and lastly, insufficient insurance benefits to cover the cost of psychosocial visits. Off to the right is a chart indicating those barriers, the ones that were prioritized, the two prioritized barriers, alongside the monitoring tools, survey, and methods to address. The stages of implementation completion process model. Again, my particular project is in the implementation phase. Particularly, it is in the fidelity monitoring and program launch phases. So in the fidelity monitoring phase, a purveyor, which in this instance is going to be the quality improvement specialist, will be engaged and onboarded to support the next implementation cycle. The quality improvement specialist is going to be expected to engage with stakeholders and implementation team members on a daily basis, offering feedback on the implementation success and/or barriers encountered, so that way we can know and fix those in real time and address them before the completion of the next 30-day PDSA cycle, hoping to get an improvement in the efficacy of the implementation and potential adoption by the organization. And stage 6 is the program launch. So the baseline data was retrieved from Epic for the head and neck and endocrine clinics to compare with post-implementation data. And the implementation launched in December 2019, which coincidentally is a high volume month. A large volume of the PNSs were collected during December to compare and begin analyzing the fidelity of the intervention. So, in addition to adding the purveyor to our implementation team, we're going to continue monitoring some of the existing intervention processes and ensure that we're collecting adequate volume of patient information to be able to compare to baseline data as well as to initial PDSA cycle data, and then monitor ongoing through re-engagement activities of patients and caregivers, and providing them evidence-based research, as well as the EHR compliance and chief medical executive engagement to have the social work referral permissions revised so that they can go ahead and refer patients who have been evaluated and identified for psychosocial services. They will no longer have to rely on a provider or AP to enter that referral into Epic. They will be able to enter it directly, which should shave off some time and allow patients to be scheduled for their psychosocial visit during their visit to the endocrine or head and neck center, and which kind of closes that loop for the patient following the CSSRS. So during the EBI evaluation, the purveyor for the next phase of the implementation will be, again, the quality improvement specialist. The quality improvement specialist is an internal expert whose role is to review and evaluate the efficacy of processes, initiatives, and interventions to ensure it meets the organization's needs and does not harm patients. Additionally, the purveyor will monitor the fidelity of the EBI and provide continuous feedback to the implementation team, who will serve as the communication connector at each stage of the QIF stage of implementation during the next PDSA cycle. So off to the right, you see the monitoring activity, the actor, the phase, and stage, as well as the question. So just kind of rattling these off. The monitoring activity, the first one is revised Epic permissions for social work. The actor is the EHR compliance and chief medical executive in phase 3, stage 11 of the QIF model. And the question is, have referrals by social work for psychosocial services increased? The second monitoring activity is patient and caregiver engagement. The actor is the implementation lead and champions in phase 3 and stage 13 of the QIF. And the question is, has there been an increase in completed psychosocial visits? And then the last monitoring activity is continuous feedback loop and EBI support. And the actor is the purveyor, phase 3, stage 12 and 13 of the QIF. And the question is, has uptake of the intervention improved? So the idea is that the questions relate specific to the actor or executioner of the monitoring activity. The REAIM framework will be used to evaluate the implementation outcomes of my EBI and answer the implementation evaluation questions. Following the initial PDSA cycle, stakeholder interviews were conducted to gain feedback from their perspective on the implementation success or failure, along with any barriers and/or facilitators that influence the organization's adoption of the EBI. The practical, robust implementation and sustainability model, PRISM, was used to better understand the barriers and facilitators that influenced implementation outcomes. Off to the right is a chart indicating the implementation stage, implementation activity, the TMF used, the implementation questions, and the implementation outcomes. So the first implementation stage is stage 5, fidelity monitoring. And why is this stage appropriate for my project? Well, it's necessary to understand and incorporate stakeholder feedback to increase adoption. What is the implementation activity associated with this? It is to monitor efficacy of the implementation and provide feedback about implementation determinants. Which TMF was used? PRISM. And what are the three things that were done under the PRISM model? Implementation setting and reevaluation, stakeholder reengagement, and system enhancements specific to the EPIC system. What are the implementation questions? Can increasing stakeholder engagement through regular feedback sessions increase uptake and overall effectiveness of the implementation? And the outcome I'm looking for is fidelity and effectiveness. The second implementation, stage 6, is the program relaunch stage. And why is this stage appropriate for my project? It is necessary to re-engage stakeholders based on the barriers identified during the initial implementation phase. This approach should effectively reduce known barriers and increase reach and feasibility of the EBI. What is the activity associated with this stage? To convene stakeholder work groups, which include social work roles will be revised in the EHR to refer patients to psychiatry and integrative medicine, and patients and caregivers are going to be re-engaged, informed, and educated about the EBI. And what levels of the PRISM are these related to? These information sessions will be scheduled with patients and caregivers. The purveyor will be engaged and re-educated on the status of the project. And the implementation team members will be reintroduced to the EBI to reset for the next implementation cycle. That is how all of those are related to a program relaunch. The implementation question to be reviewed and assessed is, can providing restricted EHR access to social work increase downstream referrals to integrative medicine and/or psychiatry? And can education sessions with research material supporting EBI help improve patient participation in psychosocial visits during the next phase of implementation? And what outcomes are we looking for there? We're looking for reach and feasibility. In conclusion, psychological care is underdiagnosed and consequently psychosocial services are underutilized in cancer settings. The use of distress screenings was developed to address this practice gap, but studies show that distress screening alone does not effectively identify patient referrals for services. MD Anderson Cancer Center was selected as an ideal setting to pilot the intermediary response screening because of its trialability and adaptability. Plus, MD Anderson was utilizing a distress screening tool called the PNS and made psychosocial services available to patients. Unfortunately, the evaluation step was absent from the distress screening process, which limited accurate identification of patients for psychosocial services. So why does this matter? Well, according to the CDC, 1 in 3 people diagnosed with cancer will experience psychological distress. Only 1/3 will speak with their doctor, and even fewer will receive treatment. Cancer patients are at double the risk for suicide, with head and neck patients having a suicide rate of 3 times higher than the general population. Once holistic care is promoted and normalized, mental health care becomes less stigmatized, patients are more adherent to cancer treatment, quality of life is improved, and there's less risk for cancer recurrence. If you have ever been personally shaken by the loss of a family or friend whose death could have been prevented or even prolonged if psychosocial services were made available to them and their family, then you deeply understand why this is such a critical topic. Stakeholders will be reconvened in the next phase of implementation. With barriers removed and facilitators leveraged, there is a higher likelihood of adoption. However, if the EBI is unsatisfactory, decisions on whether to revise and re-implement the intervention will be heavily debated, given the resources that are duly allocated to support the intervention. But even if the EBI does not result in a 3 to 5% increase in referrals and completed visits, it still may be beneficial to revise the patient needs screening administration to include the IRS evaluation step as a way to engage patients in their care. Currently, without this evaluation step included in the patient-nurse encounter, patients aren't engaged, so they are blindly responding to a distress screening that they may not necessarily understand, but they feel required to complete. But by engaging them in their own care and helping them to understand what this patient needs screening is doing and how it can help to support their cancer journey and their psychological well-being is going to be an important part to continue having as part of the PNS administration. Thank you so much for listening. Thank you so much for taking time to listen to my project. The barriers that were encountered on the initial PDSA cycle, the reconvening of stakeholders, the addition of new stakeholders, the strategies that are going to be deployed in the next PDSA cycle, and just all of what has gone into creating this process enhancement, as well as deploying it in the pilot clinics. This has been a heavy lift, but it's been wonderful, and I appreciate you taking time to listen to it. Should you want to contact me or want more information, please feel free to reach out to me. Again, my name is Shanika Noel, and my contact information is on the slide in front of you. Thank you so much again for listening. Take care.